Let's speaker is Professor Mette Berger. Is emeritus professor in Lausanne University and leader of the guidelines, ESPEN guidelines in micronutrients. Her topic is supplemental parental nutrition in the ICU. Thank you, Mette.
Thank you for kind introduction, and thank you to ESPEN for organizing this important ICU session and inviting me. Well, supplemental parental nutrition. My two colleagues have alluded to the place of PN, and we are going now to see what can be done. My conflicts of interest, mainly that I'm a guideline person. Well, 20 years back, my team and Pierre Singer's team published very similar studies, and this is the aggregation of both. And what we can observe, we observed in patients who were studied prospectively with indirect calorimetry to measure their energy expenditure, was that some deficiency in energy balance was tolerated without any problem. But acute underfeeding, shown as a cumulated deficit of energy, was associated with increasing acute underfeeding complication, wound healing issues, pneumonia, ventilator-associated pneumonia. And when this high level, minus 10,000, was reached, then it was bad. Our study was misunderstood, and quite some studies were conducted to say, well, then we start full feeding early on to avoid this, which has proven to be wrong. But look at this cutoff of minus 6,000. It was actually problematic, but not confirmed by others until this study came out. And it comes from the United States. It's in the surgical ICU, and they looked at their patients who had been, with prospective data, either classified as having been fed with lower energy deficits, protein deficits, or higher deficits. And what they showed was that ventilator-free days, ICU length of stay in hospital, was actually longer in those with higher deficits. And the study was actually called Getting People Home. The number of patients who were discharged home, not having the large deficits, was multiplied by 3. So not going into large deficit was important. Okay. Archer Vazenda has, and others have actually insisted on the individual's management. And this we tried to summarize in this paper also, that we have to look at the individual. Not all patients are alike. Okay, but what is supplemental parental nutrition? It is the use of intravenous nutrition, i.e. parenteral nutrition, to complete an enteral intake, oral or enteral, that is not covering the needs of either energy or protein or micronutrients, abbreviated as PN. The route can be central or peripheral venous access. Okay, that is what we're talking about. We, Geneva, Lausanne, conducted one of the first studies where we tested this strategy in ICU patients. Convinced that progression is important and not full feeding, we actually randomized the patients on day 3, measured their energy expenditure, and randomized them either to continue enteral, because the patients had to have a working gut, or to complete the deficit to the measured energy value. The patients were 60 years, I mean, typically European ICU patients. How did it look in terms of energy? Well, at the end of the 3 days, the patients typically had these minus 4,000 kilocalories of deficit that we knew were not harming the patient. But then, actually, we continued in blue with the enteral. You see that we were actually delivering actually a very tiny amount of additional, but we never exceeded the measured energy value. It looks like this. The patient is in deficit For whatever reason, the patient has not been fed. These are the first 3 days. And something is started, but is still not there. We measure the energy expenditure, which is actually lower than the initially prescribed value. And then we start parenteral nutrition to complete that, while increasing the enteral feeding, and then we, of course, stop the supplemental parenteral nutrition as soon as we are on measured target with enteral. And okay, proteins, we were not getting higher than 1 gram per kilo with this strategy. We were delivering micronutrients to all patients. And of course, these patients, even extubated, they are not able to feed themselves. Is this strategy much applied in Europe? Well, you have European study that shows that this strategy is used in some patients, but not very much. And what you observe in this European study is the amazing range of energy intake. Some people just seem to receive whatever, and this is problematic. This dispersion is a worry. And what do our guidelines say? Well, we have insisted with Annika on the progressive strategy, on being low if you have equations and not in direct calorimetry, and actually to increase only to 100 after a few days. Okay. What was the result of what we did with our SPN trial? Adjusting individually, we had a 30% reduction of infectious complications. And these patients were selected. It is not every patient all the time. It was patients with a working gut, but not well working, actually typically those that Annika has described. And in these patients, it had an impact, that we avoided overfeeding. It resulted in actually a improved immunity, and we had a trend, well, it's a 0.06 to less muscle loss. What we had was an important sparing of money, 3,300 Swiss francs per patient who had this strategy because of less infections. We have updated our guidelines partially, and in these updated later, we insist on avoiding overfeeding. Early full feeding, Ian, we are just not just saying don't do it. And also progressive for PN. And those who cannot tolerate EN, well, consider that PN can be given. Because we know that if we get beyond some deficiency level, the body is also going to have a problem. Arthur told about the 1 million question when to start. I mean, it's a progression which tells us how to continue. There is a surgical study which has some weaknesses, but which has shown that in surgical patients, this issue of energy deficit also matters. But they have also started early PN on day 3. And then the late group actually has done poorer with more infections. So clearly there is a cutoff for the immunity also in terms of energy you deliver to your patients. The data are there. I mean, it's well conducted with some weaknesses, and the patients who are fed to a reasonable target from day 3 on, progressively, they are doing better. There are systematic reviews to try and find out, because all our studies are more or less confronted to the number of patients. And they elected 5 studies, including our study from Switzerland, and the small one we did to complete, and they have been looking at that. And the conclusion regarding presence of infection is always in favor of the cautious SPN. Mortality, not that clear, but well. So when enteral feeding fails to fulfill energy requirements SPN may be beneficial as long as you don't overfeed. There is another systematic review published in 22. So they have taken other studies, including also ours, and they find trends towards improved physical outcomes, but they encourage continued research. Note that in this study, infections were not considered, and that is one of the main points we found to be matter to the patient and to the budget of our hospital. When and why? Actually, other studies have also tried to look at what is happening, this time in oncology. Oncology is a part of medicine not often seen in the ICU, but in that specialty, the doctors generally focus on oncological treatment and much less on the nutritional treatment. And in these patients, there is a benefit. They are candidates for this strategy, but let's come back to the ICU. The route matters. I have often heard about the risk of central venous catheters. We're lucky to live in countries where we can say that we have a zero catheter infection policy. This is not true worldwide. And in several countries, to put in a line to give supplemental parenteral nutrition is a risk. So clearly, we also have to balance that, and therefore, the use of a peripheral line, which is clearly associated with less risk of infection, can be used. And this can also be considered in ICU patients, although all of us know that in our patients who are inflated by fluid resuscitation, peripheral lines are just not that easy, but can be considered because usually the transition between enteral feeding to full feeding takes a few days. So peripheral lines might be used for those 3 to 4 days to fulfill that. You cannot deliver the concentrated amounts, but supplemental parenteral nutrition is by definition to give something between 500 and 800 kilocalories because you're completing an enteral feeding. Discussing the issues of why it is so difficult to introduce SPN, some of us, also sitting here, met around the table to try and define what were the problems. And actually, there are a high number of uncertainties, and European showed that it was used only in 10% of nutrition days. What are the key factors? Well, there are many. Persistent hemodynamic instability is perceived by some as being a problem. Not in my hands. Prolonged intolerance to enteral is considered as a metabolic sign. Being in prone position, hesitance to increase enteral nutrition, insufficient data, pre-existing malnutrition, yes and no. But there are also good things, and actually in favor of SPN, the surgeon who says, don't touch the gut, I'm scared, you go in with enteral. We know they are wrong because the sutures love enteral nutrition, but anyway, some surgeons still remain in last century. So clearly, there are things which make people reluctant to consider SPN due to uncertainty mainly. Well, look at this diagram, but look especially at the date. This I published with my then boss in 2001. This was before we knew about the importance of glucose control, etc., before it had been integrated. And when you publish something, and Medicine et Hygiène is our local medical journal, means you have been practicing this for quite a while. I always always defending this progressive approach, and just to stabilize the patient first. So this has to be applied with everything, and all our studies addressing energy deficit prevention is something we should consider here with the progression. But then we showed that there was a cutoff. You shouldn't go beyond minus 6,000 accumulated deficit. And actually, we are between Charybdis and Scylla, from underfeeding to overfeeding, and we have to individually look at the patients. Annika published a very nice analysis of the trials which have been conducted over the time. And she has also clearly, with this, identified that compared with early full feeding, like in a few trials, the permissive underfeeding has less complications, but no difference in outcome. And the studies which have been positive are those who have applied our ESPEN and ESICM strategy. Because there is one more reason not to try and go full in immediately. It's the shown by Arthur early energy production. If you measure total energy expenditure, we have something called endogenous energy production. And if you full feed by either route, you overfeed. You overwhelm an organism which is already fighting to survive. So this strategy is wrong, and this is why actually we know that compared to measured energy expenditure, we should never push too much. And this is a strategy we have been developing in a tutorial some of us published now 1 year ago about how to use measured energy expenditure to adapt your metabolism. And we insisted on something that people don't usually talk about, which is the respiratory quotient. If you are on the low side, you either have a technical problem down there, or you are in the low values underfeeding your patient, optimal range being 0.8 to 0.9, and actually overfeeding when you are there. So this is the important part actually of indirect calorimetry, which is not sufficiently used. And it looks like this. Look at this measured energy expenditure, but also look at the respiratory quotient. The patient here was receiving close to 3,000. It looks as an enormous value, but we have the proof that this is used by the organism by using the RQ. So when you use actually supplemental parenteral nutrition, you have to monitor. And actually, if you don't have indirect calorimetry, you have some labs which can help you adapt your feeding. Blood glucose, levels of insulin that increase to maintain blood glucose, triglycerides, liver test, but that takes more time. So monitoring is required. And again, insisting here on this progression. And supplemental parenteral nutrition is just integrated in this strategy. You start, you search for hypophosphatemia, you provide liberally thiamine to prevent refeeding. And in several ICUs, we deliver multi-micronutrients early. This is not parenteral nutrition, no? But it's parenteral administration, while we increase whatever. And actually, with that, individual monitoring of energy and protein intakes is required to detect eventual under or overfeeding. Underfeeding remains an issue in the ICU and is associated with complications. Don't get me wrong, it's not full feeding, it is accepting some level of deficiency, but not letting it run out. And actually look, when you have the possibility, at a respiratory quotient to confirm what you're seeing. So ESPEN is just a tool you integrate in the rest of the management and the monitoring of the patient. And of course, our patients do differ. Thank you for attention.
Thank you, Mette, for your kind presentation. Time for questions, please.
Hello. Hi. I have a question. Thank you for a great lecture, as always. During these 3 lectures, there was discussion regarding overfeeding, but can we do harm to the patient with the micronutrients, especially regarding parenteral nutrition, if, for example, patient can tolerate up to 60% of enteral feeding? Thank you.
Well, very important question, actually. When your patient comes in, usually he or she has been a few days without anything. And actually, the metabolic alterations are directly influenced by the micronutrients involved in the mitochondrial function and the energy production. So to provide doses of micronutrients, which are those which are the parenteral nutrition normal doses, not talking about high doses early on, even if you're not feeding parenterally, is a way to support an organism in a way which never harmed. Not talking about high doses. High doses have never brought anything. I've always been defending the close to nutritional doses and using the parenteral nutrition complements of trace elements and vitamins. So if you provide these with thiamine in relatively higher doses, 100 to 300 milligram, depending on the size of your patient. Of course, if you have a patient who is 120 kilo or a little lady 40 kilo, it's 100 versus 300 milligram of thiamine. And this has been proven. I have one trial, randomized, who showed that you reduced the trauma patient's length of stay with this strategy. So again, no high dose, just supporting, progressing either enteral or parenteral. And when you are, well, on parenteral, you always deliver it. The problem is that if you deliver only half a bag and have put your micronutrients into it, you only deliver half the dose of micronutrients. So this is why in our ICU, we deliver them separately to ensure that they are getting their full dose. I hope this answers.
More questions? I have a question for you, Mette. Really, supplemental parenteral nutrition needs personalization, and then how we can deal with the standardizing of bags of parenteral nutrition with the use of 3-chamber bag, ready-to-use parenteral bags.
Very important question, because as you know, Nutrition Day showed that patients tend to receive 500 kilocalories, 1,000 kilocalories, or 1,500 kilocalories, meaning bags. And this should not be the case. This means that doctors sadly are only prescribing bags. I trust that you who are sitting in this room are better educated than that. The industry is providing small bags. So when we are using SPN, we use the small bags, and we don't prescribe bags, but milliliters of the solution corresponding to an amount of energy. And we don't distinguish between proteins and energy. We prescribe the energy because, as nicely shown by Arthur, exactly, we also have to progress them. So we take the smaller bags, we don't use the big bags, and that, by doing that, we don't throw much away.
Thank you. If any more questions? Okay, then thank you, Mette Berger.
Thank you.
Thank you, all the speakers, and thank you for your attention.